Good morning, everyone. Welcome to Radiographic Anatomy video section. And this time around, we'll be talking about C-spine or cervical spine. This is specifically designed for 200 level medical students, allied medical students, and anatomy students. However, postgraduate students in medical physics, biomedical engineering, and others who have found it useful can benefit from it. My name is Nicholas Irure, a radiologist, anatomist, and a clinical scientist. Yeah, we'll start by knowing the three main views that are taken in the cervical spine. One is the lateral view, which gives you the best information, and the frontal view, which can be called AP, anterior posterior, and the odontoid view or open mouth view. In all of this, we will be talking about the lateral view because it gives more information than the other views. Before we talk about cervical spine, radiographic anatomy, we have things we have to know. We have to be sure that the bones are aligned. And how do you know that the bones are aligned? You can see the posterior end of the mandible and the angle of the mandible. As long as they are there, and with the way the lucency that you're seeing here, it tells you the bones are aligned. The next one you want to find out is the cervical spine itself aligned? So, and how do you find out that? Is that first, there's the line called the anterior line that goes in front of the cervical vertebrae, and there's a posterior line that goes behind at the posterior end of the cervical vertebrae. The posterior line is formed by the posterior longitudinal ligament, while the anterior line is formed by the anterior longitudinal ligament. There's another line which we'll be talking about, the spinal laminar line. It goes in the posterior end of the laminae. Then the last line we'll be talking about is the posterior spinal line. And the posterior spinal line starts from the level of C2. This we'll find out later. So now that we are sure that the cervical spine is well aligned, then we'll now talk about the cervical vertebrae itself. First is the C1, which is equally called the atlas, and it goes on. You have the anterior end of it, which is the anterior arch. Then you have the posterior arch. In between, you have the dense or odontal process protruding into the C1. The C1 typically has no body. So it is the posterior, it is the protrusion of the odontal process that gives it its stability. And C2, we now have, C2 has this body, okay, and has the odontoid process, which is another atypical finding or which is another peculiarity to the C2 vertebra. Okay, and as we go further down, we'll talk about the C3, C4, C5, C6, C7. We are quite aware that the cervical spine has 7 vertebrae. And in all of this, if you notice from C3 down, we have the superior border being flat and the inferior border being curved with a projection, anterior projection. But however, as we go gradually towards the thoracic vertebrae. We will now see the inferior border actually flattens out. I'll go over that again. The superior border of each vertebra is flat and the inferior border is flattened. As we go further down into the thoracic spine, the inferior border becomes flattened out, as you can see in C7 compared to C4. Then we'll go further. There's that lordotic view, which is the normal part of the normal architecture of the cervical spine. Before I go further, this arrangement with each cervical vertebra is the natural morphology of the cervical vertebra at that level. However, if you can see between each cervical vertebra, you have the intervertebral disc. But the intervertebral disc is being represented at this level between C2, C3, C4, C5 as a lucent area. Why is it lucent? Because it has no calcium. We all know that the cartilage doesn't have calcium, so that's why it is lucent. So you can appreciate the intervertebral disc between 6 and 7 vertebrae. After we've gone through this, then we can now talk about the dense area. This dense area posteriorly is different from the anterior part of the vertebral body. It represents the pedicle. This is the pedicle of C4. 1, 2, 3, 4. Yeah, that's the pedicle of C4. And it's like a summation of images where the transverse process, it's right in front of it, and there's a superimposition that occurs. As you may be aware that when it comes to radiographic images, because it is a 2D process, some of these images are superimposing on each other. So because of that, we can now say this is the pedicle, and furthermore, we have the lamina for C4, and subsequently we have the lamina, we have the spinous process. So the spinous process, which we talk about really, like I said, when you talk about the posterior spinous line, it usually starts from C2 to C7. Why? Because the spinous processes of C1 is very short, okay, and forms part of the posterior arch of the C1. Furthermore, you want to ask me, where is the spinal canal here? The spinal canal is usually located between the posterior vertebral line and the spinal laminar line. Okay, so what that means is that posteriorly it is formed by the spinolaminar line, and anteriorly it is formed by the posterior line of the vertebrae, posterior longitudinal line. Then we go further to talk about the joints. The apophyseal joints, or the facet joints as it were, they are usually synovial joints, and what you can appreciate here is this lucency between the vertebral body above and the vertebral body below signifies the apophyseal joint. And usually the apophyseal joint is formed by the, we are going to go to the C6 and C7. The apophyseal joint is formed by the inferior articular surface of the vertebral body above and the superior articular surface of the vertebral body below. So with this, we can simply say that the lucency here is that of the facet joint. And what is the significance of that? The facet joint on its own is formed by, is a synovial joint, which allows cervical cerebrate to be able to glide. And in doing so, in doing so, it helps in movement. And what kind of movements? We are talking about movements such as flexion, extension, lateral movement, and rotation. In all of this, they help in combination with the intervertebral disc to stabilize the cervical spine and at the same time to help in movement. When we talk about all of this, we should not forget the soft tissues. The soft tissue here, anteriorly, this is the region of the nasopharynx that comes from the nose race, and it is this lucent area, and it goes down, and it is joined by the oropharynx, which comes from the mouth, okay, and they meet at the level of the hyoid bone, okay. At that level, they now form the laryngopharynx. So laryngopharynx, when you go further down, you now have at the level of C5, you now have the larynx, and we go further to form the trachea. So because of this arrangement, the soft tissue, which is prevertebral soft tissue that is in front of the cervical spine, is divided into two. C1 to C4, usually the soft tissue is called retropharyngeal soft tissue, whereas from C5 down, it is called the retrotracheal soft tissue. These soft tissues are important. They have some clinical significance. Furthermore, we'll talk about the epiglottis. Epiglottis, with an eye of faith, epiglottis, as we know, closes when you are swallowing or during injection, and subsequently, it prevents food from getting into the trachea. With this, I think I've summarized by the fact that we should be able to identify the number of vertebrae in the cervical spine, should be able to identify the vertebral body, the pedicles, the spinal, the laminae, and the spinal processes. We shall be seeing in my next video. I want to thank you very much. Remember to like, subscribe, and share. And also click on the notification button.